Nitesh Patel is a very special human being. He's currently a resident at Rutgers, which is near and dear to my heart because that's where I went to medical school. One day, I promise I'll tell you guys about my backstory. But Nitesh actually, after about 5 years of training, or 4 years of training, came to Lenox Hill on one of his research years and did a fellowship, basically, a skull-based and endoscopic fellowship with David Langer and John Bookvar, and got involved in some of the research that Dr. Bookvar was pushing and kind of took it and ran with it. Currently, he's a chief at Rutgers, and he'll be going on next year to do a fellowship with Ricardo Comatar down in Miami, probably one of the busiest brain tumor fellowships in the country. And afterwards, without a doubt, we'll go on to be a leader in the field of neuro-oncology, at least I think. Although he's been doing a lot of spine surgery from what I hear lately.
Busy.
But that's what you got to do. Other things, Nitesh is actually joining me now on Tumor Talk. He's going to be helping out with the Journal of Neuro-Oncology and myself in the tumor section with our weekly webinar. And that'll continue after Brain Turns. So I suggest you all stick around and stay involved and keep listening because it's a great educational format. And we really tailor that to lay people as well as physicians and researchers. So you see his Instagram handle there. You see his Twitter handle. He takes great photos. So I would definitely follow, light him up. But otherwise, I don't think he can introduce the rest of this himself. This is fantastic research, and I'm really happy to have him here. So go wild, buddy.
Thank you, guys. Thanks, Randy, for having me. Josh, appreciate it. The Lenox Hill team is dear to my heart. It was by far the best team I've ever worked with and the most organized. And I'm sure you guys have all seen it through this Brain Turns program, through the Tumor Talk sessions, the YouTube channel, and of course, David Langer and John Bookvar, who are both extremely dear to my heart. So I just, sort of want to go over some things with you guys. I was asked to talk about intra-arterial chemotherapy for brain tumors, which as a topic I got to really look into a lot as a fifth year sort of enfolded fellow, as Randy had suggested I did with Dr. Bookvar and Dr. Langer. So I'm going to talk a little bit about that, but I want to give everyone a primer for brain tumors too. I know this is a mixed crowd and people are at different levels of training. So I want to make sure everyone can take something away from this talk. At the same time, I just want to say that if there's anything you have questions on, anything in general, including this talk and medicine, neurosurgery, or just career advice, feel free to shoot me a message on Twitter, Instagram, and I'm pretty active. I will quickly respond to you and, definitely be ready to give you any advice or any pointers. So let's sort of start off here. Acknowledgements. So this talk has been a sort of a mosaic of several talks I've given in the past, and most of the slides come from different talks, and I've added on a few more things, and I couldn't have done it with all of these people that are sort of mentioned here, including some of the funding sources we've had. I have no disclosures. So let's first talk about brain tumors in general, and we'll start off with a very basic concept. I usually ask myself 3 questions when I look at a brain tumor. The first question I ask myself is it extraaxial, intraaxial, or intraventricular? And, for those of you who are familiar with some basic brain anatomy, extraaxial means, as you see here in B, it's a lesion that's sort of pressing on the brain. It's not necessarily growing from the brain or within the brain, but rather it's pressing on the brain. Now, it's not as obvious as this sometimes. Sometimes it's lower in the brain. It's sometimes tricky to tell. And that's when you look at an MRI, you look at different sequences, you may even ask your neuroradiologist for their interpretation. And they're usually very good about that. And then sometimes you just don't know, and you won't know until you get in there if you're gonna do open surgery or access the tumor. Sometimes intraaxial. These are more lesions that originate within the brain or lesions that get to the brain via blood source. For example, something that's metastasized to the brain. And then sometimes they can be within the ventricular system. The brain itself has surrounded by CSF, and then the CSF also lives within the ventricular system of the brain. There's a lateral ventricle, there's a third ventricle, there's the aqueduct, there's a fourth ventricle, and that continues down into the spinal canal. So sometimes these lesions can actually originate within the intraventricular system or spread there as well. So that's the first question I ask myself, is kind of, where is this lesion? Now, as far as where it is, the other important question you have to ask yourself is it supratentorial or infratentorial? Tentorial refers to the tentorium, which is here in red. It's basically this dural layer that sort of separates the occipital lobe from the cerebellum. And essentially, that is a good marker for describing an anatomic location for the tumor, We sometimes refer to these tumors as PFOS, or posterior fossa tumors, when they're infratentorial. And you'll also notice there is an age differential. For younger patients, typically pediatric patients, tumors are often infratentorial. That doesn't mean they can't be supratentorial. And then for adults, they can be infratentorial as well. However, those that are infratentorial tend to be metastatic, or they come from somewhere else. And typically, though, you're often seeing tumors more supratentorial, meaning above this red line for adults. Next question I ask myself is it primary or secondary? Did it originate in the brain? Did it come from somewhere else? If you have a patient and they have a lesion in the brain that's newly found, but they have a history of, say, breast cancer or lung cancer or something else, your suspicion should be high that it may just be related to their primary malignancy. But again, that doesn't mean that someone with breast or lung cancer can't get a primary brain tumor. It's also still possible. So after I do that, the next question I sort of go on to is organizing my thoughts into how these things can be treated. So treating brain tumors. I'm sure you've had a lot of talks from various experts, and I know Dr. Bookvar gives amazing talks about brain tumors in general. But I, for once, when I was early in medical school, and even early in my residency training, I sort of wanted to organize things in my head of how I'll go about to actually, create some sort of treatment algorithm for these. So I simply classify things surgery or non-surgery. Now, again, this is not a full-blown list. This is a very quick summary. There are nuances to all of this, and a lot of overlap as well. But for surgery, there's the most obvious answer is you take the whole thing out if you can get to it safely. The next thing is you take out part of it, because if you take out the whole thing, you end up hurting the patient. And you want to do the first thing is do no harm, right? So you want to try to limit how much you take out before you actually potentially hurt the patient. And then the next option after that is something just like a biopsy. You get a small piece of tissue, and then you send it to the pathologist, who can test it for all kinds of things. They can look at different tumor markers. They can look at it under the microscope and describe it for you. And that really can dictate treatment. In fact, sometimes all you need is a biopsy, and chemotherapy and radiation will do the rest of the work. And then there's a category of other. Now keep the other in mind, and that's what we're going to dive into today. Then there's non-surgical options. There's chemotherapy, there's medical therapy, and of course there's radiation. As far as radiation goes, there's a whole gamut of different options there. There's stereotactic radiation, there's whole brain radiation, there's IMRT. There's also radiation seeds and brachytherapy, which we'll sort of touch on briefly. But I want to primarily focus on this other category here. So let's talk about surgery first, since that was the first part of this. From a surgical standpoint, again, I try to keep things simple. I classify them based on, what I think is an appropriate approach. Now you can go the traditional, which is an open craniotomy. This is the word straightforward is sort of misleading, but it's the most common way things are usually approached in the brain historically. This picture diagram you see down here is from the Neurosurgical Atlas by Dr. Cohen-Goodall, which is fantastic. If you haven't already signed up for it, anyone who's interested in neurosurgery or neuroscience should sign up for it. It's free. There's a ton of videos. There's a ton of figures. I mean, these illustrations are incredible. So this is, for example, a pterional craniotomy, which is basically a frontal craniotomy. And this is on the right side of the patient. We typically put the patient in a fixed position using these 3-point pins. We call this the Mayfield head holder. And then we'll mark an incision for a pterional, for example, here. There's small variations to this depending on where you look or who the surgeon is. There's ways to do a mini pterional. You can do a more expanded approach. All depends on what you're trying to treat. And then we'll open our incision. We'll take down the temporalis muscle. We'll take off the bone. And then you'll notice dura, which will flap over after we cut it. And then you'll see the frontal lobe. And then you'll see the temporal lobe and the sylvian fissure here. This sort of webby, fuzzy, white appearance on here is arachnoid and pia, which again may need to be violated if you're chasing a tumor that's intra-axial, meaning within the brain parenchyma itself. Sometimes a tumor is sitting around the surface and you can get it out fairly easily. Sometimes it's sitting on the surface and it's surrounded by blood vessels, which makes it more challenging because you want to try to minimize how many blood vessels you take. And then we put the bone back on after we're done with our surgery. Other things you can also do is approach tumors, for example, in the ventricular system with a tube. You can make a small incision, make a small craniotomy, and then place Vicor is a company that makes these tubes. There's other companies as well, but you can place a tube in and access the tumor through a tube. And then another approach is endoscopic, where you do this often for pituitary cases, where we'll take a camera, put it through the nose, and get to the sella, which is the space, sort of empty sinus space before you get to the pituitary region, and we can access tumors in the pituitary or cellular region from that approach. And that's a pretty nice approach because it doesn't really require any incisions you can see, and patients tend to do well for the most part. Then there's non-surgical approaches, chemotherapy, which has almost an infinite number of iterations for it, and then radiation. Now, I've listed some very basic radiation categories here, which is gamma knife or stereotactic radiosurgery. There's IMRT, there's whole brain radiation, where you basically radiate the entire brain. And then there's also a new and coming technology, there's proton beam. Now, this is a image from a gamma knife system. This sort of helmet here that you'd see in like an X-Men movie or something, actually directs your radiation source. Now, in this case, they usually use cobalt. This frame that's actually put onto the patient is actually screwed onto the patient's skull. It's done when the patient's awake with some local sedation or a local anesthetic. And then you position the patient. You can do quite a bit of work with just this radiation process. It's pretty amazing how far technology has come. Things we would operate on 15, 20 years ago are no longer operative diseases. You can treat them with gamma knife. And then there's something in between. Now, I use the word something in between very loosely. When most people think of surgery, they think of a knife, they think of cutting things open, doing an open approach. It's something you can see with your own eyes. There are other things that you can do that you don't necessarily see them with your own eyes, but you're using other forms of imaging to see them. So it's a combination. One is laser-induced thermal therapy. And, I'll speak to Randy, and maybe perhaps I can give you guys a primer on this in the future. But what we're going to talk about today is super selective intra-arterial chemotherapy. And that's a mouthful, but we're going to get into that and sort of break it down so everyone has a good idea as to what it is. Very briefly, I did mention the word laser, and everyone loves hearing the word laser. But, we do have the technology to just make a small hole in someone's scalp, place a navigated laser catheter, and essentially burn the tumor from the inside out. It's pretty exciting. It sounds more promising than sometimes it is, but I think it has a strong future. And, I've done quite a bit of work with that as well. So again, here's a Venn diagram, sort of how I like to think about these things. And, I just want to emphasize to everyone, we're surgeons, yes, and our job is to operate. We're trained to operate. But in fact, the most important thing we do is to try and find reasons not to operate. If you're ever questioning whether or not someone needs a surgery, there's a good chance they probably don't, or you should be very careful as to what your approach is going to be. Last thing you want to do is hurt somebody. So again, surgery isn't always the right answer. And sometimes you just got to avoid it and try to find better solutions that'll be better for the patient. So what is intra-arterial chemotherapy? Now, I used the big term before, super selective intra-arterial chemotherapy. Let's just talk about intra-arterial chemotherapy first. The bottom line is, if a tumor is going to grow anywhere in the brain or anywhere in the body, tumors need oxygen and nutrition. In order to get oxygen and nutrition, they need a blood supply, no matter what. So if you think about it, that blood supply is essentially a highway or a direct road to that tumor. What is intra-arterial chemotherapy? Let's continue on this sort of trajectory here. Typically, let's talk about just the top first. When you think of chemotherapy or any medication, it enters through a vein, enters circulation, gets to the heart, and then from the heart, it distributes to the entire body, and your hope is it gets to your target. For example, in this picture, you have a brain tumor in this little diagram here. Now, the issue here is that when it does enter circulation, not only does it go to your target, it can also go throughout the body. And we all know that chemotherapy is designed to kill tumor cells. That's the goal. It can also be harmful to normal cells. So there are side effects that do occur. Furthermore, the amount of chemotherapy that actually makes it to the lesion or the target is a fraction of what you actually insert in the patient, or actually enters into the patient. There's a small fraction in some cases it's a higher fraction. However, when you use an intra-arterial, meaning a non-venous approach, right, you can actually access a main vessel that feeds the tumor. You can use the highway of blood vessels to access one or two or more particular blood vessels, and it sort of delivers the chemotherapy directly to the target. And it limits how much of the chemotherapy disperses throughout the system. And in sort of corollaries that you get a higher dose of it in theory to the target. Obviously, when I first heard about this, I think I was probably somewhere in medical school, and I said, well, how come no one's thought of this before? This is obviously logical. This must be perfect. This is the solution. This is the cure. Well, they have. In the 60s and through 90s, I mean, this was really something that, and I have a historical side we'll go over very quickly, but this was explored quite a bit. I mean, they were injecting, mustard, sort of chemotherapeutic agents for non-Hodgkin's lymphoma, and the outcomes seemed promising. The problem was that the techniques were limited. What do I mean by limited? Well, the available imaging modalities, the type of angiographic wires, the type of catheters, basically the ways you can access a tumor were limited. And what I mean by that, I'll illustrate in this sort of picture here. So this is the internal carotid artery in this very basic brain diagram. This is a coronal view of the brain. These are lateral ventricles here and here. These are the frontal lobes. These are the temporal lobes here. This is the Sylvian fissure here. And you can see this internal carotid artery goes up, splits into the MCA here, and gives off the ACA, the anterior sort of cerebral artery here. These vessels here are lenticular striates. If this was our tumor, if I were to deliver chemotherapy at point A, it'll travel up the blood vessel, it'll go here, it'll go out this way, in addition to going to the tumor. If, however, I was able to access these vessels, which are much smaller than this, I can, in theory, deliver chemotherapy almost directly to the tumor or directly to the target. This is what we mean by super selective. We're intra-arterial, but we're also being very selective as to which vessels we use to deliver the agents. As I promised, here's a brief history. In the 50s, they used nitrogen mustard into Hodgkin lymphomas patients, and they saw pretty nice outcomes, but also pretty bad side effects. In the 60s, Wilson used, again, nitrogen mustard for brain tumors via the internal carotid artery. But again, that meant it was going to almost the entire hemisphere of the brain, and it's pretty toxic. In the 70s, this sort of work expanded to going after the next problem. Sure, you can deliver chemotherapy to the brain via blood vessels, but there's something else in the way, the blood-brain barrier, which is something we're going to get to. But nonetheless, through the 90s, the advances continued but slowed down a lot because the endovascular techniques simply weren't there yet. We didn't have the technology. We were sort of not moving at a fast enough pace, but that changed a lot in the early 2000s. So what do I mean by all this? Well, here's an angiogram from probably around 60 years ago. Here's an angiogram, which you typically see now. Anyone can tell that this picture is far better. There's far more resolution. You can make out little blood vessels. Not only can you make out little blood vessels, today's technology also allows us to access these smaller blood vessels. So if a brain tumor, let's say, is here, you can actually access a small branch and actually get to just the brain tumor and limit how much chemotherapy you deliver to the body, essentially targeting the tumor itself. So why does all this matter? Well, we have a problem. The first problem is that of brain tumors, malignant gliomas are extremely challenging to treat no matter what we've done. The last time we made major breakthroughs in the literature were probably 2004, where we came up with the Stuke protocol for the treatment of glioblastoma. And it was a bit of a breakthrough, and we sort of still stick to that approach even now, which is almost 15 years later or more. So despite decades of treatment, despite all the research, the billions of dollars have been put into this, we have almost no cure. We have no long way to ensure that there will be long-term survival. Our standard of care is surgery, which can be complete resection, subtotal, or even just a biopsy, followed by intravenous drugs and also radiation. But survival, again, is limited. For grade 3 gliomas, survival is between 36 and 41 months. For grade 4, it's 12 to 15 months. I mean, these are patients who somehow, are found to have a brain tumor, and, statistically, they're going to be probably dying in the next year and a half. They go from essentially being completely normal like any of us to being very sick very fast. And no matter what we do, we've only made marginal improvements. Here's the other problem, the blood-brain barrier. Now, I don't know if someone's touched upon this in the brain turns curriculum before. I'm sure Dr. Bookvar has, but the brain is a very protected place, as you'd expect it to be. The blood-brain barrier is basically a barrier that's created around the blood vessels that feed the brain. And it's designed to not only keep things from getting in, but also keep things from getting out. And this is sort of dictated by these tight junctions. These orange, yellow sort of cells are endothelial cells, and they're sort of linked together by these tight junctions. And this really limits what can truly passively pass into the brain, because you also have these astrocyte foot process on the other side, sort of protecting things. So there's a wall. It's a strong wall, and it really limits what can get in or get out. So if we're going to use intra-arterial chemotherapy, we better find a way to disrupt this barrier, to let the chemotherapy sort of diffuse into the brain area or make it across. And we use something called mannitol for that. Mannitol is a hyperosmolar agent. It essentially dehydrates the body in a sense. So if you were to dehydrate these cells and decrease the amount of water in them, the little junctions between them will actually open up. And it'll allow, in theory, passage of whatever you'd like to deliver to the brain. So let's look at this in context. On the left, you'll see an angry-looking brain tumor. By convention, right is left and left is right on almost all radiologic imaging of the brain. So this is actually the patient's right side. This is the patient's left side. It's because these images are obtained feet up in terms of orientation. So this is what appears to be a glioblastoma, and I'll tell you it is. Now, this is located in the right frontal region, okay? And you can see that this thing looks very different than what normal brain looks like. And there's also a little darkening around here. All right? This is called hypointensity, hypo meaning low. And it's hypointense relative to the brain because this is edema. Likely the source of this edema, probably this thing. And then if you look at the lesion itself, it's very heterogeneous in appearance. This is contrast that's sort of lighting it up, but the whole thing's not lighting up. It's because it's sort of a chaotic environment. It's not normal. Now, if you were to take a microscope and sort of zoom in on what's going on here, we can see these sort of red areas here, these little blood vessel lining cells, the endothelial cells, and then you can see the brain tumor cells around it. Now, I want you to keep note, these darker blue cells are brain tumor cells, so are these lighter blue cells. However, these lighter blue cells are, in theory, supposed to be persister or sort of cancer stem cells is the way to put it, or glioma stem cells. Meaning, if one of these other darker blue cells dies, this lighter blue guy can actually generate another one and propagate the lesion. For high-grade lesions, it's theorized that there's a lot of these guys, and that's what leads to recurrence. Now, if we were to disrupt this sort of red cell or endothelial cell layer, we can, in theory, get diffusion of substance across and target everything. The big question is, where do all these cells live? How do we get there? Here's another example. I think Dr. Bookvar showed this on one of his talks recently, but this is a case from Lenox Hill. It's a left thalamic lesion. There was a biopsy done only because this is in a deep location. You don't want to go and take this out. You end up hurting the patient if you take the whole thing out. But this was noted to be IDH negative, MGMT negative as well, and it was noted to be a glioblastoma. So a fairly poor prognosis from the get-go, and something that you look at and you're saying, well, this is going to be a real challenge to help this patient. But it wasn't necessarily a challenge because we applied some of these new techniques to it. Here's an image from around 4 years later. Remember, these patients, I said, statistically live 12 to 15 months. This is 4 years later. And you can see the significant reduction in this lesion. Here's a timeline. I know for sure Dr. Bookvar showed this to you already. Biopsy, September 2015. We gave standard chemotherapy and radiation, which we give for all glioblastomas. And then we also gave intra-arterial chemotherapy. Which agent? We gave bevacizumab, and I'll go into that in a little bit. And we gave 3 doses to it according to the protocol for this trial. And you can see how this changes from 2015 to 2016. And then go on further. By April 2019, the lesion was essentially probably reduced to maybe 10% of it. The patient was off steroids and doing pretty well at that time. So why does this happen? How come in this patient we're able to achieve this, but we can't achieve it in all patients? Well, there's a concept of these light blue cells, which I mentioned earlier to you before. I'm going to go back. These cells here, I said, are the persister cells. They sort of continue to exist and they sort of regenerate. Now, if you were to go and do surgery on this, you're almost guaranteed to have these remain near the blood vessel. You can't get this whole thing out with the GBM. In fact, it's spread beyond what you can see. So there's these cells sort of continuing to persist, and these can potentially regenerate. That's what we call minimum residual disease. Disease you can't necessarily see, but it's there. And we'll go back. So minimal residual disease in GBM, the cancer stem cell persister sort of hypothesis. And the goal is to deplete these cells. So yeah, you can do surgery, you can do chemo and radiation the traditional way, but you won't necessarily get to these cells. And we theorize that the best way to get to them, at least based on what we currently have, is getting through the intra-arterial route. These cells love to live near blood vessels. And this was shown actually by Calabrese et al. In 2007. Nestin is a marker for these stem cell nests, these cells that sort of live near blood vessels. And they live right near these red areas, these blood vessels. And the reason why they live there is because it's logical. That's where the first wave of nutrition and oxygen comes from the body. And these cancer stem cells love it. When you're taking a brain tumor out, you try to limit how many blood vessels you take. And the whole goal is to try to not take too many vessels because you don't want to give the patient a bad stroke or something like that. In doing so, in a high-grade lesion like a glioblastoma, you may leave some of these behind because, again, they're near the blood vessels, and you're going to try to avoid them if you can. So why do these cells persist? Well, these cells release hormones, and there's something called autocrine and paracrine signaling. And for some of you who've been in medical school or have a medical background, you've heard these terms before. It's often used in the endocrine courses. But these cells sort of secrete substances that not only help themselves grow, but help cells around them grow. basically creating more things like themselves. The VEGF, or vascular endothelial growth factor, was discovered as a growth factor that promoted blood vessel growth. Just because it's named that doesn't mean that that's the only thing it does. It's also released by these glioma stem cells. And these glioma stem cells also have high levels of receptors for them. So the stem cells will then release this VEGF, and not only will it stimulate other stem cells and other tumor cells, but also stimulate themselves. So both autocrine, meaning self-stimulation, and paracrine, meaning stimulating cells near them. So the question is, well, VEGF actually is, if it's so common, how do we inhibit it? Well, there is a way to inhibit it, bevacizumab, which is Avastin. And that's what we're going to get into. Another point I want to make is VEGF not only promotes growth of these cancer stem cells and propagates tumors, it also, in theory, promotes radioresistance, meaning the cells are resistant to radiation. I told you earlier that radiation is one of the mainstays of treatment. So, like I said, this can be reversed with bevacizumab. And there have been sort of multiple studies using different mouse models. Here's a study from 2008 that was published in Cell Cycle. It looked at, in the control group, no bevacizumab, and in the bevacizumab group, the number of these glioma cells. Now, the U87 represents a type of cell that's sort of in a lab setting, was significantly reduced, as was these NSCD stem cells population was also significantly reduced. So it had a positive effect. Now, this is, again, in a mouse model, right? Not in humans. So this is sort of in vitro. Here's a more of a visual description of this. Here's a control, and you can see these red areas are the blood vessels. You can see these little green dots are these nestin positive or cancer stem cells, glioma stem cells, I should say. And this is no bevacizumab. This is bevacizumab. And you can see when bevacizumab was given, there was a significant reduction in blood vessels, as you'd expect, but also in the number of these nestin positive or glioma stem cells. So, well, why not give it? Well, actually, it has been given, and it is given, and that's the reason why we sort of came up with this protocol. We found that bevacizumab is not only cytotoxic, but it's also cytoreductive. It kills and reduces the number of tumor cells, and this was dose dependent. Going to doses even as high as 15 milligrams per kilogram for human patients led to significant resolution. This is pretty exciting stuff when this came out in the late 2000s. Again, here's a sort of graph showing this. And you can see with duration of treatment, 10 days, the number, and based on dose. So 25 is the red line here, and 5 is sort of the other line. And you can see the gray line here. When you increase the dose, you had a better response. So why not use bevacizumab up front for glioblastoma? Well, it increases cell death in theory, and it also decreases the number of glioma stem cells in theory, especially at the time of minimal residual disease, meaning getting to those persister cells, those light blue cells we talked about earlier. So logically, the next question to ask yourself is, well, this bevacizumab has been around for a while. I mean, why are we sort of just talking about this now? Well, it has been around for a while, and there have been multiple studies, big trials too. This is from the New England Journal, a very reputable paper that's been cited several times, and it's published back in 2014. This looked at intravenous, not intra-arterial bevacizumab versus placebo. And in short, the only significant difference was found was that intravenous bevacizumab led to an increase in progression-free survival, but no change in overall survival. Quality of life and performance status maintained longer in bevacizumab, but there was no major difference in overall survival. So it wasn't as exciting as it seems. Another study in the New England Journal as well, this is by Gilbert et al. Back in 2014 as well. This was a double-blind placebo-controlled trial with almost 1,000 patients. And in the end, 637 were randomized. So there was a significant dropout, but still quite a big number. And they found something similar. Progression-free survival was longer with bevacizumab, but overall survival was not. So both these papers, sort of dampened the excitement over bevacizumab. It seemed like this miracle drug that was working so well intravenously, but there was thoughts that, well, perhaps it's not, because the thought was that bevacizumab was decreasing the amount of blood vessels to these tumors, and therefore they just weren't enhancing as much, but they were still there, and that's what the thought was. So we didn't necessarily buy this, and I'll sort of get to that in about 3 slides as to where that last sort of point went. But around the same time, Bookvar and some of the guys in New York started asking the questions. Well, perhaps we can target these persister stem cells via an intra-arterial approach. by giving high dose intra-arterial bevacizumab, meaning not intravenous, do it intra-arterially. This is a study that actually looked at intra-arterial bevacizumab, and they looked at when the blood-brain barrier in 3 groups of mice, when the blood-brain barrier was intact, meaning not open, and they gave intra-arterial bevacizumab. Then if they opened the blood-brain barrier and then gave intra-arterial bevacizumab, and then if they just left the blood-brain barrier closed and give intravenous. And they found that among these 3 groups of mice, the best outcome and the best uptake of bevacizumab was highest when the blood-brain barrier was open, meaning mannitol we talked about earlier, and intra-arterial bevacizumab was given, which is again, not intravenous. It's sort of a diagram that I stole from Bookvar about 2 years ago. So again, before is your sort of cancer cells here, your brain tumor cells. These are these sort of persister cells, these cancer stem cells living near the blood vessel. They give mannitol via a microcatheter, and then that opens up the spaces between these red cells, and these little Y-shaped guys, which are your bevacizumab or whatever other chemotherapeutic agent you want to give, will sort of diffuse in and sort of attack these cells first because they're close to the blood vessel. By depleting those cells, you sort of can theoretically decrease the amount of recurrence or decrease the amount of cells that can lead to recurrence. Not only that, but you can also target the more mature brain tumor cells. So here's how it's done. Here's actually Dr. Ortiz and Dr. Langer. And this is them in the angio suite at Lenox, sort of picking the right blood vessel to target a tumor. They're going from the groin into sort of a femoral approach to the brain. And they have these long guide wires, 100 centimeters or so, or even longer to get up to the brain. So here's a tumor. Here's sort of, you can see this blush of this tumor here. All these blood vessels feeding it. And you can pick one main vessel that sort of goes to it. And in theory, you want to target that vessel. Here's some early work by Bookvar and also Dr. Rena from NYU, where they go over the safety and tolerability of intra-arterial bevacizumab. And this is some of their early work, which led to more work that's been recently published. So I talked to you guys earlier about all that excitement over bevacizumab in the mid-2000s, and those papers from 2014 and 2007 that basically said, oh, bevacizumab looks great. The patients their lesions appear to shrink. There was a thought that, well, maybe what's happening is that the number of blood vessels to the lesions is actually decreasing in the sense that they're not letting as much contrast leak out into the tumor. So the tumor's still there, but it's not lighting up because the contrast is not getting to it. So this is a big question. So is basically Avastin or bevacizumab just masking the effect of what we're seeing on the MRI? So the tumor's still there, just not lighting up. So Bookvar, sort of asked this question back in 2012, and this paper is actually in AJNR, and they found that using MR spectroscopy, that was not the case. There was a true anti-proliferative and tumoricidal effect on tumor cells. Now, this again was a limited study, right? This is a phase 1-2 study, which led to these findings, and it's a relatively small subset of patients. So again, it has to be taken with a grain of salt, but this sort of showed that you can't just shut it down necessarily. There may be some value in this. So Dr. Bookvar and the team at Lenox sort of took this and ran with it. And they started continuing their trial development and formulated a trial in which they were dosing 15 milligrams per kilogram for glioblastoma patients of bevacizumab. When I came on, they had this upfront intra-arterial Avastin study going. It already enrolled more than half the patients. And I got to work with Charisse, Tamika, Mona. Lucas was one of the former interns that worked with Dr. Bookvar. And we sort of sat down and looked over all this data. And we found some fairly promising results. So this was designed as an open label, single arm, non-randomized trial. And we looked at the safety of repeated intra-arterial Avastin. This goes to that picture I showed you guys, that lesion from 2019 and 2015 to 2019, how it just sort of shrunk over time. This was one of those patients. And what we found in this study was that, again, this is an interim analysis, right? The study's not complete yet, but we had sufficient number of patients to sort of look at some statistics. And we found that the overall and progression-free survival actually improved. And patients were able to tolerate 15 milligrams per kilogram safely. We did record adverse events, of course. Now, keep in mind that all of these patients were simply just a biopsy or subtotal resection, meaning they had quite a bit of residual tumor still left. This is a trial protocol, again, surgery, which was usually a biopsy or subtotal resection. Most of the lesion was actually kept in the patient because it wasn't safe to take out. This was followed by first dose at day 30 of intra-arterial chemo. Then you do your second dose at day 120, and then the third dose thereafter. And this was done subsequently with temozolomide and radiation, which is standard of care. In this interim analysis, and I'm sure this is probably increased by now, the recruitment goal for the study was initially 27. We had 20 at the time, of which 14 were sort of evaluable for the actual study. And what we found was that on average, here's our sort of demographics, patient age, average lesion volume. These lesions were about the size of a golf ball, or maybe a little bigger. What we found, an overall survival for this subset was 38 months, and progression-free survival was 29 months. This is vastly different from everything else published in literature, and it got us pretty excited. But again, you have to take this with a grain of salt, right? This is an interim analysis. This is a relatively small number of patients, only 14. And of course, this is not necessarily a randomized controlled trial, which is the gold standard in research. But this does show that there's promise in this, I think, and it's definitely worth pursuing further. And I'm kind of excited to see where this goes. So where do we go from here? The bottom line is there's value here, I think. And using an intra-arterial route theoretically makes sense, and it is feasible considering the techniques we have now. They're able to do things in the endovascular suite, which even 5 years ago were thought to only be surgical. The technology is changing almost every week. I mean, they have all kinds of devices, all kinds of catheters. They can get to the smallest vessels in the brain with pretty good accuracy as well. So are there other drugs we can give? Well, cetuximab. I know Dr. Brookvar has a few ongoing trials that he's looking at to deliver other chemotherapeutic agents intra-arterially, or even combination therapies. And new technologies forming almost every day, as I said. On the topic of combination therapies, there's other ways to open the blood-brain barrier too. It's not necessarily just by mannitol. The guys up in, I believe in Montreal and Ontario are looking at focus ultrasound. There's also multiple groups in the US looking at this, essentially using ultrasound waves, which are sort of focal into one particular area, meaning a tumor area, and that sort of the ultrasonic waves open these junctions between these endothelial cells. And this may allow passive diffusion of substances to the tumor. Then there's also lasers. Again, lasers are always exciting. The word lasers makes everyone turn their heads. And laser-induced thermal therapy is used for epilepsy, is used for brain tumors. There may be value in having a laser procedure done for a deep brain tumor, then following it up with intra-arterial chemotherapy. Especially since there is some evidence that shows that laser-induced thermal therapy, after you ablate a tumor with LIT, may have an effect on the blood-brain barrier. It may temporarily open it because of the heat and because of the vascular damage to that small area. So there may be an optimal window to deliver chemotherapy intra-arterially after laser-induced thermal therapy. So with that, I sort of want to close off and leave some time for questions. I think we've been talking for around 40-something minutes now. There's a couple things, I know a lot of you guys are at multiple levels in training. Just remember to always pay it forward. I've been extremely lucky to have known Randy since I was in medical school, and he's sort of been in touch over the years and has been a great mentor to me, a great friend. I mean, we're texting each other weekly on cases, and I'll send him things that I've done. I'm like, hey, what are your thoughts on this? As he said, I've done a lot of spine these last few weeks, which is good because I've got a whole cranial year next year, and it's always good to be a well-rounded surgeon. And then another quote from Brookvar. He always used to quote Pasteur as if it was his own quote, but chance favors a prepared mind. Never stop looking into things, and be curious. Read on things, and it's amazing that you guys are getting the chance to participate in this Brain Turns program, because I think it really exposes you guys to different things, and you'll see things here where you'll go and read on somewhere else in your life in a few years, and you're like, oh wait, I learned this before, and it just makes it that much easier to learn. Then finally, something that my dad always told me, something I tell everyone, including the juniors that I sort of teach here at Rutgers, is success is not defined by where you stand, but rather who's standing next to you. It doesn't matter what you've accomplished yourself. It matters who's with you when you're done, because that's truly your legacy, and that's truly your contribution. Everything in medicine, including neurosurgery, is sort of an academic tree. Your job is to make the person you're training better than you ever were at their level. And if you accomplish that, you've met success. There's my Instagram and Twitter handle. Feel free to send me a message anytime. I'll share my email as well with the team. again, honestly, anytime you have a question, anything, you feel free to message me. I'm pretty fast with responses. And thank you all for having me. Thanks, Randy. Thanks, Josh.
All right, I'm going to open the chat up for questions now. Can you see the chat?
I'm doing the stop share and I'm pulling up the chat now. All right, great. I see the chat.
Yeah,
Great.
a bunch of them come in pretty quick. So, yeah, we got 1,600 people here excited to ask you questions.
Oh, it's amazing. Okay, let's go. How should we tackle this? Should we just go straight down the list?
Go for it. Pick the ones you think maybe are best because you can't get to everything.
Yeah. So again, I'll start off with Himani's question, finding the appropriate and most effective treatment option. What are other challenges you face on a daily basis? I think the hardest thing, I'm sure, Randy will agree with this, is talking to families. And when you're delivering a tough diagnosis, it's never easy, especially when you're trying to sort of paint the picture. As I said, some of the survival with these cases, 12 to 15 months, and these patients are sitting in your office talking to you as if just as I'm sitting in front of you, they look completely normal. And then you have to tell that patient, look, statistically, here's what we're looking at, because they're going to ask you, well, how much time do I have? And you don't want to necessarily give them a number of months, but you have to give them a little bit of truth. But you have to also be hopeful and be optimistic, because they're going to entrust you. And I know in the last talk, David Brody and Randy both spoke about customer service, and you always think of that word from like the standpoint of business. Well, in medicine, there's also customer service. Your patient have to be confident in you, or else they will go to somebody else. They have to trust you, and they have to know that you're on their side. You're not there to just do what you want to do. You're a counselor, right? And that's your job as a doctor, as a physician. Your job is to guide the patient, or as a provider, never to coerce the patient. Let's see. Next is Surin Lee. How much of a difference does a super selective approach make in the recovery of patients? It's a good question. So typically these procedures are done as an outpatient sometimes, or you access the groin, almost like a cerebral angiogram. You deliver your therapy, and the patient will spend a little bit of time in the anesthesia recovery for a couple hours and potentially go home. Sometimes spend the night. But the recovery from otherwise is fairly straightforward, unless there's some sort of catastrophic issue or outcome that resulting from a risk. Patients can have a stroke. They can have hemorrhages. It happens, and I've seen it. Doesn't necessarily mean it happens in all cases, but there's always a risk.
Do you maybe want to take a moment just to go through your path to how you got to where you are today?
Yeah, no, it's great. I definitely will. So I grew up in Jersey City. I went to college at Rutgers, New Brunswick. I did one of those combined 7-year BAMD programs. So I went to Robert Wood Johnson Medical School. I think I was in my first year when Randy had just finished medical school, and we had briefly met at the time. And then I stayed at Rutgers for residency. So again, college is 4 years in the U.S. Medical school is typically 4 years, and then residency for neurosurgery is 7 years on top of that. So I'm at the tail end of that. I'm in my 7th year of residency now, so it's been almost a decade and a half of training to get to this point. I've stayed at Rutgers for everything. I went to Lenox for my 5th year of residency. Our program has a research year where we're supposed to spend time in the lab, but I decided to actually go and work with Brookfarm and Langer. I thought it was a great opportunity, and they were very sort of gracious in letting me come and work with them. It was probably my best year of training. I sort of finished that year, and I came back for my 6th and 7th years of residency back to Rutgers. And here I am now. As Randy said, I'm going to Miami with Ricardo Komatar to do a oncology fellowship after this, and hopefully get an academic job as a sort of associate or assistant professor somewhere after.
Great. Thank you for giving the story. You can go back to taking questions now.
All right. Somebody asked in terms of drugs, bevacizumab, temozolomide. I think Tedrick asked this question, which is better? Well, temozolomide has had more studies, I think, at least with more positive outcomes. So that's standard of care. Bevacizumab is also widely used, but less so often, I think, now because of the fact that there are so many other options. And then some of the studies for intravenous use, at least, weren't as promising as they thought they would be. It's still used, though, but it's not necessarily a frontline agent. Let's see. Some websites, recommendations for neurosurgery research articles. I think the most useful website that I tell my junior residents is Neurosurgical Atlas by Aaron Cohen-Goodall. It's a beautiful collection of articles, anatomy figures and stuff. And he references a lot of good articles, which you could read and actually come up with other ideas too. And then, of course, I think, the Lennox Hill YouTube channel is fantastic. And then I know Randy's been doing this Tumor Talks session weekly, which is actually, a game changer. I don't think anything like that exists where you have such almost an informal discussion about, various tumor topics. So if you're interested, I definitely encourage you to tune in to those things. For those of you who are Rutgers grads or Rutgers alumni yet, Rutgers represent, I appreciate that. I see that in the chat here. Let's see. How long is a blood-brain barrier open after mannitol administration? Good question. It's transient. I don't know if there's an exact time limit per se, but when we're delivering these chemotherapeutic agents, we have to move quickly. So you have to balance that with the injection rate. You can't just push the syringe and push it in. You have to go very slowly. You have to do this over several seconds for each CC. So it's not something that just stays open perpetually. It does close back down, but it's a transient thing. Let's see. My neuro resource that sort of, I mentioned the Cohen-Goodall Atlas. I think I answered that one as well. Are there side effects to bevacizumab? Yeah, there are. Again, bevacizumab is a VEGF inhibitor. So in theory, you can have all kinds of blood issues. You can have blood clots, you can have hemorrhages, you can have pulmonary embolisms. They're going to be fairly toxic, but that's why we carefully adjust doses. What failure or setback taught you the most about your profession? This is a good question. I think this is important for everyone to realize. One of the hardest things you're all going to see as you move on in training is because as you advance, you're going to have people you're responsible for teaching or training. One of the hardest things you have to do is sort of creating an environment or a culture in which you're able to maintain a level of authority or direction without being toxic. You want to be friendly with your team, and you want to make sure your team understands the goal. But at the same time, you don't want people to be too lax. And I personally have found the best way to deal with this sort of challenge or dilemma is to define a central goal for the team. Everyone should be pitching forward for the same exact mission. And when everyone's doing that and everyone's having a good time, things just will get done and people will get trained and people will be happy. In neurosurgery, it's one of the best examples of this. I have a six-man and woman team here in which we're running multiple operating rooms daily. We're running a service of 40 patients, 30, 50 patients sometimes. And it's Newark, New Jersey is a very urban environment. And our guys and girls are doing an amazing job. Everyone walks in at 5 a.m. every morning and we have the same goal. Sometimes we're here till 10, 11 at night. In fact, we were here till 10, 11 at night 3 times this week already, and probably be here today too. People are tired, but the key is you'll have to just learn how to balance everything, keep people sort of motivated. Let's see. Clinical research, I think I would sort of recommend, let's see. Somebody mentioned, do I have any advice for pursuing clinical research? Find out what you're interested in, a basic topic, keep it broad. Look up people who are doing that work, and if they're nearby you in a geographic location, reach out to them. I know Dave Brody before said, get an email address and ask for meet up for a cup of coffee or an email. That's actually the best approach. I did that actually. I worked with Dr. Shubber Donish as a med student at Robert Wood. How did I first meet him? Sent him an email. And here we are almost, a decade plus later, and we're close friends. We've published a lot of papers together, and it's been great. We've had a great time together, and he's trained me in my neurosurgery training. Let's see. Perfect. So thank you, Temi, for putting Neurosurgical Atlas here, and Ankita as well. What steps do I recommend in medical school to get into neurosurgery? It's a good question. I think it depends on where you're going to school, whether you're in the States or outside the States. As far as the States go, I would use the approach of no matter what specialty you're sort of taking a course for, you'll take an OB clerkship, you'll take a general surgery clerkship. Treat everything that you learn in medical school as if that's what you're going to go into. Because when you do that, you'll excel and you'll also master the knowledge. And then when you finally settle yourself on neurosurgery, when there's nothing else you want to do and you want to commit yourself for 7 years, everyone makes that decision at different points. Some people decide at the third year of med schools. Some people decide at the beginning. Reach out to a neurosurgical mentor at your institution. If you have trouble finding one, you can reach out to me. I'm happy to help point you in the right direction. If I don't know somebody in your institution, I can find somebody who may. I can try to put you in touch. I'm happy to, especially in the US. And start working with them. Start off with a basic project. If you haven't written anything before, if you have some experience, try to offer your experience. There might be some skill set you have that they don't have, and you can provide that. You create a need for yourself to be part of that research group. And then you slowly just be persistent. Don't let things drop. Be persistent, get things done. The last thing we want is for a student or a trainee to take on a project and 3 or 4 years go by and the project's gone nowhere. If it's your project, own it and take it. Somebody actually asked a great question. Salvador Hernandez. I just completed my EMT program. Would you recommend volunteering at the fire department or hospital more? I did the same thing about 15 years ago. So yeah, just do that and just keep going. You'll find your passion, I promise. Let's see. I think that answers most things. Josh, anything else? Randy, anything else?
No, that was great. Thank you so much for joining us today, though. I will make sure to post your socials so that everyone can get a hold of you, though.
Great. Thank you.
Thanks for coming out, though.
All right. Take care, guys. Thank you, everyone.